Now, of course, classically, lots has been learned about the organization of the language system by patients and lesions in patients and how that relates to the symptomatology. These days we have all the other tools that we discussed this morning, but that doesn't mean that the lesion analysis and phasic deficits are no longer highly crucial and relevant to get an insight into the neurobiological underpinning of human language. And one of the leading researchers in this field is Nina Dronkers. Nina has a long career in aphasia research. She is at the VA in California and also professor at UC Davis. And she has studied large numbers of aphasic patients, also and developed lesion analysis methods that have advanced the field of lesion-related research forward and discovered a number of important findings for our understanding of the neurobiology of the human language system. Nina is well recognized in the field. She is the president of the Academy of Aphasia, which is the most important organization for aphasia researchers, and also the past president, right? These presidents, these shift so soon that of the Neuro Society for the Neurobiology of Language, which is the largest organization for neurobiological researchers in the language system. So, in that sense, she is well put in order to instruct us about what we can learn from language disorders and localization. So, Nina, please.
Thank you. Thank you, Peter, for that very nice introduction. However, Carl Zillis can never be replaced, but I will do my best to keep you awake this afternoon, talking about language disorders that we see in aphasic patients, and also what those patients can teach us about the localization of language areas in the brain. Also, I like interactions, I like talks that are really interactive. So I want you to ask questions all the way through. I don't have a special section, per se. I have a little bit at the end, but we're going to kind of do this all the way through. I think it'll be more interesting for you. I know it'll be more interesting for me to hear from you. So let's do it that way, okay? So anytime you have a question or comment, just let me know. I need to tell you who my collaborators are. I'm not going to tell you all of them, but I want you to see how interdisciplinary this field is. So there are people from many, many different disciplines that really help to make this work all possible. This is stuff that we've done over the last 30 and more years with a number of people, and some of these projects I'm going to tell you about. Of course, I need to thank the people who have supported this all through the work that we've done here, and especially a special thanks to our research participants, because without them we would know nothing about aphasia, and they have been very, very gracious in allowing us to use videos and things to be able to teach other people more about aphasia. The plan for the session this evening, for our 2 hours with break in between, is to learn about different types of aphasia. And as we do that, as we go through the different types, I'm going to interleave the different methods that we use, that particularly with aphasic patients, to assess the localization of language in the brain. All right, so we're going to kind of do them in parallel. And hopefully at the end, we'll all appreciate that language is a very complex system that requires a very large and interactive neural network. Yeah, and that last bit is required by the US government. They just tell me what to do and pay my salary, so I do it. All right. I also want you to keep in mind these questions, because at the end of the afternoon, we're going to go back to these. I want you to think about what you've learned this afternoon. The types of aphasia that you might have encountered that you didn't know about, methods that we use with aphasic patients, the question of whether you can really localize language in the brain. Does that even make sense? Are some things more localizable than others? These are really big changes that we're experiencing in the field right now. Anything else? And most important, what's the most important thing you learned this afternoon? So I would really like to hear from you what you think was the most important take-home message. Right? So keep these in mind, because you will be asked at the end of the afternoon. All right, first of all, let's talk a little bit about aphasia. Let's sort of introduce it in terms of its history, the etiology of aphasia, how does somebody get aphasia, and of course we have Paul Broca's famous case, because we can't really talk about aphasia without talking about Paul Broca. What's the first fact we want to discuss? Hey folks, we take language for granted. Really? I mean, think about it. What we're doing right now, I'm speaking to you, you're understanding, we're having to put words to concepts of things, we have to put those sounds to those words, we have to put the grammar, we have to apply the correct grammatical rules to make sure that you understand what I'm saying and that I say things that make sense to you. We have to plan how we articulate these or how we perceive these sounds. All of that happens within milliseconds, and we don't even think about it, right? We've learned it pretty easily. Most of us have learned language normally. Most of us use language normally. And the fact is that because it's so automatic, we don't really think about it very much. And that's okay. It should be that way. But it's when somebody has a brain injury that we realize how complicated language really is. So acquired brain injuries can lead to speech and language disorders that disrupt one's ability to communicate. That can affect communication in many different ways. Somebody mentioned pragmatics last night. It can affect, brain injuries can affect pragmatics as well, which is also a form of communication. Typically in aphasia, we don't see pragmatic deficits because they tend to occur after right hemisphere injuries, aphasias that affect phonology, syntax, semantics, morphology tend to affect the left side of the brain. And when we get a core disruption of language functions like that as a result of an injury to the brain, we call that aphasia. So this is our working definition today for what I mean when we talk about aphasia. Okay? Well, the concept of aphasia is not at all new. The ancient Egyptians had a pretty good idea that when you applied pressure, don't try this at home, okay? If you apply pressure to the brain that has been affected by a brain injury, you get an episode of speechlessness, right? And still, despite this, the Egyptians thought it was the heart and not the brain that controlled our ability to think. So even though they had some of the data, they weren't ready to give up the idea that it was the heart that controlled our ability to think and move our bodies. It wasn't until Hippocrates and his colleagues came along that they realized speech loss can occur after brain injury, and also really interesting that the speech loss that can occur could be associated with a weakness on the right side of the body, which we still see today. So they were ahead of their time in a sense, but really the first ones to really kind of get it right. Again, we can't talk about aphasia without talking about Paul Broca. He had his most famous case, the case of Mr. Leborgne, whom he saw at the hospital called Bicêtre, which is just outside of Paris. Now this institution is actually still there, and it still is a long-term care facility. And what happened was, Broca was a surgeon actually. He didn't start out being a neurologist or a physiologist, he was a surgeon. And he went to see a patient who had gangrene in his leg. So his right side was affected. He had weakness and paralysis in the right side. His leg became gangrenous, and Broca went to see the patient in order to determine if he needed to have surgery, if the leg needed to be amputated. Okay, so imagine you're Paul Broca, and you're going, with consult in hand, down the hall to go see your patient, and you think all you're going to see is somebody who has gangrene in his leg. And instead, what you encounter is somebody who has no useful, productive language. And what Broca noted was, this patient could no longer produce but a single syllable, which he usually repeated twice in succession. Regardless of the question asked him, he always responded tant, tant, combined with varied expressive gestures. All right? Now, this is very important for Paul Broca because he'd just been to a meeting of the Anthropological Society of Paris where they were discussing the idea of phrenology and how much of the old idea of phrenology might still be valid. You remember phrenology, the bumps on the head and, areas for creativity and republicanism and, all of that kind of thing. Well, finally, when all of that died down, there was still the idea that maybe language was in the frontal lobes of the brain. So with this idea in mind, that's important to know, Paul Broca goes to see this patient, and lo and behold, he discovers all he can say is tant, tant, over and over again. That's kind of hard to imagine what that would be like to encounter someone like that. It just so happens that we had a patient in our clinic about 10 years ago who had an aphasia very similar to that reported by Broca. It wasn't tonton, it's tono-tono, as you'll hear in a moment. But the idea was still very similar, that somebody's speech could be restricted to only one syllable over and over again. All right, I'm going to play for you a video of our patient. There are no videos of Paul Broca's patient. So you'll have to make do with this one. I want you to think about what you're seeing, what you're hearing, and what your impressions are about this patient. All right?
Now tell me, why is it that you're moving actually?
Tunnel, 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 tunnel. A tunnel, 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 tunnel. A tunnel, 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 tunnel. Tunnel, tunnel, or tunnel, 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 or tunnel, 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 tunnel.
Is it because the kids have grown and the house is getting too big, or
Tunnel, 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 tunnel.
ready for a smaller place?
Tunnel.
Seems reasonable. Less to keep up.
Tunnel, tunnel, tunnel.
Yeah.
A tunnel, 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 tunnel. A tunnel, a tunnel, 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 a tunnel, 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 tunnel. Tunnel, tunnel.
Now, all your children are grown, right?
A tunnel, tunnel.
How many children do you have?
Tunnel, tunnel.
Three.
Tunnel,
Can you count that out for me?
tunnel, tunnel,
Keep
tunnel.
in mind, I asked him to count it out for me, to count out to
A
3.
tunnel, 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 tunnel.
He's writing their
A tunnel,
ages.
tunnel. A tunnel, 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 tunnel.
Now, that youngest one is always hard to remember.
All right.
All right, now you'll hear some automatic speech.
What number is this?
Tunnel.
Right? Right. Now let's count it out.
1, 2, 3, 4.
Nice.
I cured him.
Since you did 4 so well, let's go for broke. Let's go up to 20 if we can.
A tunnel. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, tunnel.
What happened?
1, 2,
It's not automatic anymore.
Okay. 1.
All right, budding aphasiologists. What did you hear? What are your impressions? You're Paul Broca. You've just walked in on a patient like this. What do you think? Yes?
Prosody is normal.
Prosody is normal, right. Yeah, how could that be? What do you think's going on there? Remember we talked about pragmatics? Who's the pragmatics person here? Pragmatics includes prosody, facial expressions, eye contact, things like that. No problem at all. 100% on any pragmatics measure we might give him. So pragmatics in aphasia is usually very, very well preserved. In fact, it's used as a compensatory strategy, a mechanism to communicate. What else do you notice?
Perception is intact.
His perception is intact. So do you mean speech perception or language comprehension? Or both? Language comprehension. Okay. How many of you would agree with Professor Margoliash? Okay, good.
Well, I don't agree.
You don't agree. Why don't you agree?
I don't agree from the fact that when he hears himself, he doesn't react on the fact that he's not producing the words that he's intended to say.
Okay.
So he's perceiving well what you're asking, but he's not perceiving well what he's saying. So
But he probably knows how he sounds like, right?
What do you think? I'll give you a tip. This film was made about 5 years after his stroke. So it's not a new, fresh situation where he's just realized what's happening. So what do you think? Does he know what he's saying?
He did notice after he counted and he went on with Tanazan, he did notice he wasn't counting anymore.
Right. Yeah, that's right. So the fact is that patients like this who have such restrictions in terms of what they can produce will use whatever they can. And in his case, all he's left with is this recurring utterance, tonal, tonal, tonal. And so he uses it to the best of his ability. He uses it in every situation that he can. Anytime he's supposed to talk, this is what comes out. But, as you pointed out, the prosody changes. His facial expressions will change. He'll use expressions. So I have to tell you this story. I'm sorry you guys have heard it before, but for instance, I asked his wife does he ever get lost? You know, does he have trouble finding his way, you know, around the house or out in the neighborhood? Or, you know, when you're out driving. He doesn't drive, but. And she said, oh, no, he always tells me where to go. Think about that, right? So I said, I'm sorry, I have to ask you, how does he tell you where to go? And she says, oh, he goes, tunnel, tunnel! Okay? There's a lot you can do with gestures, facial expressions, changing the pitch, the tone of your voice. All of that is communication. I had another patient who locked his keys in the car in the parking lot of our hospital, went to security and convinced security that he should call the automobile club to come and help him get his keys out of his car so he could drive home. And he did all that with yes, yes. So there's a lot more to communication than just words. Something to keep in mind. Something I think we probably all do when we go to a country where we don't speak the language, right? You use a lot of gestures and facial expressions and things like that in order to communicate. So that's what these patients do as well. David?
How can you judge that the prosody is correct?
Well, that's an excellent question. Let's say that he uses varied intonational patterns. Now, whether he's using the prosody correctly because he's trying to superimpose it on a phrase where the words are just, you know, substituted with tonal tonal, I don't think he does that. But he does change pitch, stress, things like that in order to change his message. So we were back at the question also of...
I'm sorry,
yeah.
if I may pursue this for a second. I mean, prosody as an output is assigned to some level of representation that has to be programmed. And, you know, pragmatic communication is not such a thing, right? It's too broad. So there must be some level of representation to which he assigns an intonation contour when he programs the output.
Therefore, it's crucial to know how his comprehension is, because we know that to a large extent infrastructure for production and comprehension are shared. So if it turns out to be the case that this guy can do complex syntax, grammatical adjustment on longer references, then it might well be the case that he's able to program his references but not get the lexical stuff. So I think that's crucial to understand what his comprehension level is like.
Okay, so we're back to the question of how well does he understand what's said to him? All right, what evidence do we have that he understands everything? Yeah.
His reading, right?
His reading and writing are very poor. Yeah. When he writes, he'll write maybe the first letter of the word he's trying to say. Yes?
You asked him about his children, how old they are, and he answered the question, right? Even with showing it the numbers or counting out.
Right, so I asked him, how many children do you have? And he did this. And I said, can you count that out for me? How would you interpret that?
Say 1, 2, 3.
Say 1, 2, 3. But what does he do instead? He starts writing out their ages. So this is actually the way he identified his children, by their ages. So when he wanted to talk about the oldest one, then he would write the age of the older one. And that was how he identified them. So in some way, he was responding to a question about his children, but he wasn't answering the question that I asked him, which was, count that out for me. That change anybody's mind? How about this? I give him 2 pictures. One is a picture of a boy kissing a girl. The next one is a picture of a girl kissing a boy. And I say, the boy is kissing the girl. Which picture do you think he chooses? The correct one or the incorrect one? The boy is kissing the girl. He has a picture of a boy kissing a girl and a girl kissing a boy. I kind of just gave it away. He points to the right picture. The boy is kissing the girl. Boom. He's 100% sure. Absolutely right. That's the one. Okay. Now I say, the girl is being kissed by the boy. Which picture does he point to? The same one, with 100% confidence. All right? So he hears the girl is kissed by the boy, which is really the second picture, and yet he hears, did I get it mixed up again? I swear this happens to me every time. Anyway, he picks the wrong picture. I know, I need to take the test and be examined. Aphasia is contagious, you know. You may not realize that. All right. So in fact, he picks the wrong picture, but he does it with 100% confidence. He is sure he understands the question. And this is what Paul Broca encountered with his first patient, Mr. Leborgne, nicknamed Tonton. Kind of mean to do that to somebody, but it was 1861 after all. So now we have a patient who is showing us, when we really press them on different linguistic structures, that he's really not understanding everything, but he thinks he understands everything. And Paul Broca's impression was that his patient understood everything too, but his problem was a speech deficit, which is why Broca thought the problem in his case was a problem with articulate language, not with understanding language, but with the faculty for articulate language. In other words, just the articulatory process. All right, what else do you hear in this patient? Any other observations? Yeah.
He doesn't seem at all aware that he has a problem because he keeps on and nobody can understand a word of what he's saying. So I find this strange.
Yes, it is, but suppose you had nothing else. That was all you could use. And you're a social guy and you want to participate in the conversation and, you know, be the life of the party like you used to be before.
Very shorter utterances and lots of gestures, I guess.
Right.
I don't keep babbling to people who don't speak the same language
Yeah,
I do.
right.
So
But what if that's all you could say? You couldn't say any other words, only these sounds coming out. Yeah.
You said he's like 5 years after, so I think he got used to it. And
Right.
he realized that he can communicate that way and with the and stuff, so that's why he reacts that way.
Mhm.
He's used also that people maybe look at him strangely.
Yeah,
So
very
this
good.
is what he has.
Very good. And, you know, we can have a very nice conversation for about 10 minutes, as long as the topic is about his family, how he's feeling that day. You know, it could be tono, tono. It could be tono, tono, tono. Well, that tells me how he's feeling. So there's a lot that can be communicated that way. When he has only this to use, he maximizes it. Yes?
What about, there's some research on redundancy in sign language, and that, you know, you can repeat gestures over and over again, but he doesn't seem to do that with his gestures. And so I'm wondering if there's, you know, any affection or anything like that with his gestures.
He did gesture like, you know, he was trying to explain that he was moving to go to a smaller house because all the kids were grown. And I think he does something like this, sort of indicating he's downsizing. And he uses gestures in his speech with his left hand. His entire right side is paralyzed, so he's in a wheelchair. But he can still use his left hand and tries to use that as effectively as he can.
Yeah, but the gestures are signaling different words and everything too. So.
Yeah, I think that would be something for somebody to look at more carefully. Yeah, yeah. Do you think he could learn sign language?
I heard about research where there also are patients with aphasias who are signers, so they cannot anymore put the meaning to the signs, so they cannot use sign language anymore. So
Right. This man understands that things have names, and he could potentially learn some signs that would represent those things, especially situations in which he needs to communicate that to his physician, his spouse, his kids, and so some of those signs can certainly be used. But this man didn't use sign language before his stroke, and it's not natural for him to do it. Could he learn sign language and have that substitute the English language that he's lost? No, you're exactly right. That he's lost a lot of abilities, and the fact that they're in English is irrelevant. It doesn't matter what language he would now learn, he would still have the same problems in all of those languages, including sign language. All right, well, yes?
So I just wondered, did you ask him more than once to count to whatever number that actually then switches back to tono on? Because it was just interesting to me that it happened to be at 12. But the thing is that there's also 2 and 10, and I thought it might be a matter of perseveration at some point, that it just he could give a certain amount of attention, let's say, to automaticity of
Yeah.
processing up until that point, but then it just goes back.
A very interesting thing about aphasic patients, even those who are as severely impaired as this gentleman, is that their automatic speech tends to be unimpaired. Swearing, naming the days of the week, counting up to 10, usually pretty well preserved. He likes to sing. He passed away, so he liked to sing. And so at the holiday parties, he would be the one who would start everybody singing. But, of course, he had to watch somebody making the words so that he could use the words. When the model drops away, then he loses. So, for example, I ask him to sing Happy Birthday, and he sings Happy Birthday to you. He has a dysarthria, so he's not really pronouncing it the way he did before his stroke. Happy birthday to you. Now I cover my mouth or I remove the example. It goes back to tono, 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 tono. But the pitch is perfect. I mean, his ability to produce the melody, let's say, David's already getting upset. His ability to produce the melody such that it can be recognized is perfectly preserved. Yes?
What about like stuttering? Is there any connection with stuttering?
Well, there are stutterers who actually are professional singers. And so there is a connection somehow between the melody being able to carry the speech output. To some extent that applies here as well, and there are treatments like melodic intonation therapy that try to build on that. Unfortunately, patients can't go very far with those, and they basically can learn some, common phrases that go with a melody, and then the melody is dropped out, and the hope is that the phrase remains, which it does much of the time, but not all the time. Yeah. Okay, yes?
I have another question, and it's only a hypothesis. There's this hypothesis that language gives us the ability to have this eureka effect learning, so that we recognize at one point something and then we are able to reproduce it. And monkeys or other mammals or birds not able. They more or less learn gradually. Are these people able to have these effects?
If I said, tell me the name of these things, and he'd say, tono, 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 tono. I'd say, okay, is it keys? Tono, 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 tono. Is it Is it a table? Tono, tono, tono. He's looking at me like, I'm the crazy one. Is it glasses? Tono, 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 tono. So is that what you mean in terms of being able to recognize what a sound pattern is that matches this object? To some extent, yes. But not in this case, in this type of aphasia, not when the utterances become longer, and especially not when they contain more complex grammatical structures. Yeah. So we're talking about different levels here, even though clinically people tend to talk about fluency and auditory comprehension and reading and writing, because those are important clinically. Linguistically, we kind of think about, well, how are his lexical semantics versus his syntactic processing problems? How does he do with morphology, even though English isn't such an interesting language, morphologically speaking? So there's all these different ways of being able to look at these questions. Also, questions we were talking earlier about theory of mind and how well patients like this can think. And what do you think? Can he think? If you put a puzzle in front of him, would he be able to figure it out? He actually built huge Lego models just from the visual instructions that were provided with the little blocks. He'd build helicopters with moving parts, and sometimes he'd, ad lib and add something extra to it that wasn't in the instructions. But if I put a more complicated problem in front of him where he had to sort of juggle pieces of information and move them around in order to make his decision, he would probably do pretty poorly.
Okay.
Yes?
So if you just put puzzles of words in front of him and want him to make a meaningful sentence out of it, would he be able to do that?
This gentleman would not be able to do that, and most patients with Broca's aphasia would not be able to do it. And in fact, this is the diagnosis a patient like this would carry. So he carries this diagnosis because it's the kind of patient that Paul Broca saw, and also because of the differentiation between his output in terms of his fluency and his ability to comprehend, and we're going to talk about that more in a moment. Yeah. All right, something really important to remember about aphasia, and it's really part of the definition. The deficit has to be apparent in all modalities. So we had the great question about whether he could read or write, and we always have to test that in order to find out if our patient really has a core language problem. So a patient who can't speak but can write perfectly well, is that patient aphasic? That patient probably doesn't really have a language disorder if the sentences they're writing are perfectly intact. They're grammatically complex, there's no mistakes. That patient is demonstrating to me that he doesn't have a language problem. He has some problem in getting it out orally. All right, so that's a modality problem. And occasionally we find patients like that, particularly patients with primary progressive aphasia. The non-fluent variety will have that characteristic. Now let's say you get somebody who can't understand spoken language. He looks at you like, I know you're talking, but I don't really know what you're saying. Huh?
You call this page, you say this is the definition of aphasia, now you give an example of a person with primary progressive aphasia, which also is aphasia. So now, how does that square with the earlier?
Because primary progressive aphasia is the result of a neurological deficit. That's a brain injury.
But you wouldn't call that aphasia then?
If the patient has demonstrated to me completely intact language, which very often this sort of, a variant of the non-fluent variant of primary progressive aphasia will demonstrate. So they'll have little Canon communicators or little, typing keyboards, and they produce perfect sentences. But as the disease progresses, they become more agrammatic. And so they're called still, in fact, many people don't call them aphasic. They'll say that they have more of a speech output problem. Right, good point. Thank you for clarifying that, yes, yeah. Okay, so somebody cannot understand language, looks at you, trying to figure out what you're saying, could be aphasic. If I say, this is what I can't say that. If I write down what I want him to understand and show it to him, and he reads it and he understands it, that person may not be aphasic, right? Because their understanding is not impaired, and we can prove that by giving him various tasks in the visual modality. But in the auditory modality, he doesn't understand it. That's a patient we would say has word deafness, which I would not include as a type of aphasia. Occasionally you'll see it written that way, but that patient still demonstrates that they have intact language. Do they have a communication impairment? Absolutely. But I wouldn't call that a language disorder per se, because they're still demonstrating to me that their language is intact. But a patient who can no longer understand spoken or written language, and whose own spoken or written language reflects impairment, now that patient is probably aphasic. Okay? Because it's a core language deficit. It's an important concept to keep in mind when we talk about aphasia. There are many causes of acquired brain injury: head trauma, tumor, neurodegenerative diseases, anoxia, alexia, and so on. But the most common is really stroke. So most of the patients that we see in our clinic certainly have become aphasic because of a stroke. And what do we mean by stroke exactly? So a stroke can occur in basically two ways. One is that a blood clot or some kind of junk that comes up off of your heart or breaks off of an artery gets actually lodged in a blood vessel. So you see there are very large blood vessels coming up into the brain, and you see how they become smaller and smaller? Well, a piece of stuff, like coming through a garden hose, probably can flow through the garden hose, but if it becomes smaller and smaller and smaller, it gets blocked. It can't pass through. And what happens is, at that point, it cuts off the blood supply to these areas of the brain. Without blood, that is, without oxygen, that tissue doesn't survive and it dies. So within maybe 10 to 15 minutes, that tissue is gone already, or certainly has been profoundly affected. That's why it's very important if you encounter somebody who suddenly loses the ability to use their speech, that you get them to a hospital right away. Better call 911 or 112 or whatever it is in your respective country to have paramedics come. Another possibility is that a blood vessel actually bursts. So you know how a balloon, when you blow up a balloon, it gets thinner and thinner as you blow it. Well, the wall becomes thinner. The same thing happens with an artery. The wall of the artery becomes thinner and it can break. Blood spills out. So it's not that the blood supply is cut off because of an occlusion. In this case, the blood spills out, it suffocates the tissue, it also interrupts the flow of blood and hence oxygen to other regions of the brain. So there's basically two ways in which a patient can have a stroke. Now let's get back to our patient Leborgne. So this is actually the brain of Leborgne. It's been kept in a museum in Paris, and we'll talk more about that in a moment. But Broca had the opportunity to see this brain at autopsy. As a matter of fact, the patient died just a few days after Broca had examined him. And what they found was a little cyst on the outer part of the frontal lobe here like this, and when they ruptured it, they found this necrotic tissue underneath. And remember, they walked in there, Broca walked in there and later brought his colleagues, thinking that language might be, that this case might be a test case for whether language was in the frontal lobes of the brain or not. And here, what do you know, they find that this lesion has affected the frontal lobe of the brain. Okay, right there. They could see that there was some changes in the tissue here, but that wasn't really explored in depth, and we'll come back to that in a moment. Then 3 years later, Broca had another case. This was the case of Monsieur Lelong. And Mr. Lelong also had these kinds of, this kind of restricted speech. That is, he only had about 5 utterances that he could use. He could say his name, Lelo, he mispronounced that actually, could use a couple of numbers, and otherwise his speech was also severely disrupted. And when Broca was able to look at this brain at autopsy, he also saw, this is the inferior frontal gyrus, the middle frontal gyrus, the superior frontal gyrus. This is the insula, which is exposed in this case, which you should never see. Okay, so we're looking at a really atrophied brain here. But this is what Broca noticed at the very back of the brain, of the inferior frontal gyrus, which would be only in area 44. That's where the lesion occurred. And that led Broca to think the integrity of the third frontal convolution, and maybe of the second, because in Leborgne's case, the lesion also went a little bit higher, he thought were indispensable to the exercise of the faculty of articulate language. So again, they describe things in terms of these faculties. Well, and when you really, work hard and show more cases that imply that this area of the brain is affected, related to a certain kind of a disorder, your name eventually gets associated with it. Broca's area became associated with this particular area and known as an area for speech production. All right? Broca did not assign this himself. This was only many years later that people referred to this as Broca's area. Along came Karl Wernicke in 1874, and he had a very different kind of patient. His patient couldn't understand language very well, but the speech came out fluently. It just didn't make a lot of sense. And Wernicke reported this in terms of a much larger model of how he thought the brain worked, and associated this more posterior part of the superior temporal. Actually, he pointed it in a very general direction. In the one case that he had that came to autopsy, who, as it turned out, also had Alzheimer's disease. I just want to point out that these were not the best cases for localization, yet they were extremely important for us to start thinking about the idea that different things or different processes might be localized in different regions of the brain. Okay, so it became known as Wernicke's area and language comprehension. Then, of course, we have later, thanks to Lichtheim and Geschwin, the notion that the arcuate fasciculus, a fiber bundle, actually connected those two regions to each other, and we got the model that Peter already spoke about this morning, so I won't belabor that. You still see this model in textbooks all the time, all right? It's not wrong, it's incomplete. Okay, it's really much more interesting than this. Now, let's take a look at, we have to remember this was a model that was developed 140 years ago. Okay, I hope we've learned something since then. And as we'll see, hopefully we have.
Can you also add here that, of course, the whole model was based on single word processing, right? So they didn't include all the higher levels and so on.
They didn't even know about the higher levels and linguistic levels and things to look at. Absolutely, right. So, no, we certainly don't, I'm not dissing Broca and Wernicke, okay? What they did was incredibly important. But in fact, let's not forget that that model died out. And for about 100 years, nobody thought about the Broca-Wernicke model. There were all these other kinds of models that came into play instead. And it wasn't until Norman Geschwin, the neurologist from Boston in the 60s, noticed that, hey, you know what, that wasn't a bad model. That still gives us some pretty good idea about lesion localization. And if we don't know, because if we don't have the tools to look and see where the lesion is, that still gives us some pretty good ideas about which regions of the brain might be affected. Problem is it only works about 65% of the time. All right, so let's take a quick look here. This is a slide by Steve Small. It's a really bad quality because it was a little, actual slide that was used. But basically what he did was went through neurology textbooks and pulled out the areas that different textbooks noted consisted of Broca's area, all right? So here are the different textbooks, and here's where they localized Broca's area. Some disagreement. It gets worse when you talk about Wernicke's area. Right? So nobody really knows exactly where Wernicke's area is, and in fact, Wernicke didn't really define it very well. He talked about the posterior superior temporal gyrus, again in a case that also had Alzheimer's disease. So it kind of makes us think about, are those models really adequate? So has anything new come to light in the last 140 years? Do we know anything more about how language is processed in the brain? Well, I certainly hope so, because otherwise I wouldn't be here. In fact, we all wouldn't be here, right? 140 years have gone by. We have way better tools now. We don't have to wait for the patient to come to autopsy before we can look at the lesion localization. We can test them in the morning and walk them down to the scanner in the afternoon, get an MRI scan, a CT scan, and see where the stroke occurred. We also have a much better understanding of the language system, as Peter pointed out. Language is much more complicated and much more interesting than just thinking about it in terms of production and comprehension. There's so many interesting different levels that we can look at. And of course, we have a better understanding of the disorders of speech and language that can occur after an injury of to the brain. So I want you to remember that if you learn nothing else from this afternoon, brain-behavior relationships are much more interesting than just two brain areas and a fiber tract. We're going to learn about a lot of new areas and a lot of new fiber pathways that also play an important role in language. So that's your take-home message number one, okay? All right, let's talk about the basic syndromes. Let's talk about methods of lesion analysis and lesion location as we go through here. I'm going to present to you sort of a Western model. I say Western because I work with a lot of wonderful colleagues in Russia. And there, of course, the method that is used for classifying syndromes is Luria's method. Luria was a brilliant physician who really understood about the underlying deficits that occurred in patients, and hence developed a beautiful system of classification for language. I'm going to talk about what we use in the West, or, I don't know, this was the distinction that was presented to me, where basically we have 7 major classifications of aphasia. And really the distinction is broken down by fluency, comprehension, repetition, and naming. All right, so those 4 categories have to be tested in order for us to know what type of aphasia the patient might have. What else would we need to know? What we talked about before. On top of looking at how well they speak, how well they understand, how well they repeat, and how well they name things, what other 2 modalities do we need to look at? What else would we need to test to know that they have an aphasia and not just a modality problem? The writing and the reading, exactly, right. So that has to be tested as well. Aphasia syndromes group together clusters of signs and symptoms, okay? When we talk about a Broca's aphasia, we're talking about a whole laundry list of things that have gone wrong in this patient's output or this patient's language. So in that sense, naming people by aphasia classifications isn't really helpful. But it does represent a convenient shorthand. So we can say, oh, I've got a Wernicke's aphasic I'd like you to take a look at. Okay, so now the person has a general idea of what the patient's problems might be, knowing that that patient is going to be different from every other patient they've ever seen that has a Wernicke's aphasia. Okay, they are all different. They have the basic same problems, but there is a great deal of variation. And they're not very good for localizing, really, in terms of brain areas. This is basically the model that we use. All right, I'm just going to go over this quickly. Basically, our first distinction is between non-fluent and fluent. So the first patient you saw, how would you describe them? Fluent or non-fluent? Tono, 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 tono. How many say fluent? How many say non-fluent? Well, you're all right, because he is fluent in terms of how easily that tono, tono, tono comes out, right? But is it productive? Does it really tell you very much? Can you find out for him, all right, what was it you had for breakfast this morning, right? So we would actually call him non-fluent. When we test his comprehension, he's relatively good. He gives us the impression he understands a lot. But in fact, when we push him on complex grammatical constructions, he doesn't do very well. So we say relatively good. Then we get to his repetition, which is always going to be impaired. If I say the word window, he'll say tono. If I say the word pipe, tono, tono. Right? It's not going to be an exact repetition of what I say. In other words, what patients repeat is going to be just like what they usually produce. All right, so that's our first distinction, non-fluent and fluent. And the other things are categories that we also look at to help us distinguish these things a little bit more. All right, so let's take a look at another patient with Broca's aphasia. Now, I'm going to put you to work again. I want you to think about this patient. What's going on? How much does he understand? How much is he communicating? And is he different from the first patient that we saw, who also carries the same diagnosis?
All right, so tell me about the meal you had at Max's.
Oh, yes. Way over the 2 weeks, Livermore.
You're going to go there?
No. Last, hungry. Hey, that's what I like. Max's.
Did you drive over there?
No, but...
That's what you were thinking about when you were...
Yeah. Hey, garage there, my mother. That's...
Okay, he said mother. He's trying to say his wife.
Sister.
So he says sister, mother and sister.
Pat?
Yeah, Pat.
Your wife?
Yeah.
Mm-hmm.
Wife.
So you're going to call her up and say, Pat, let's go to Max's.
No. Here, that's okay. 2 weeks. Livermore's nice.
Mm-hmm.
No, but coffee. Oh, and
Do you think he likes food?
That's fabulous. And
All right. What do you think? What are your impressions? Yeah.
Seems to have more comprehension of when he's not being clear in that he says first mother, but then he stops and he understands what he said and it's not correct.
Mm-hmm. Yeah, so he produces a word, realizes it's not the right one, tries again for another one, is in the same semantic category, which we call a semantic paraphasia. And then when I ask him, you mean, and I say his wife's name, he says, yeah. Says her name and acknowledges that it's his wife he's talking about. Right. So he knows when things aren't coming out right and tries to correct them. And although you see he struggles with that, he ultimately succeeds because I give him a choice. Do you mean your wife? And he can say yes or he can say no. And he'll be accurate, by the way. Yeah. What other impressions? Yeah.
Sorry, he also seems to be missing linking words.
Yes.
He seems to just say the kind of talking thing he needs to, so cough, maybe nouns, he gets out. Maybe he says something.
Right. So he really focuses on the content words. He tries to get out as much as he can that will convey the most information. Okay, do prepositions and function words convey a lot of meaning? Not really. If you're going for the big bucks, you're going to really want to go for those nouns and verbs that will represent what you're thinking. And you do rely on the other person to help you fill in the blanks. What else? Yes?
It seems that he doesn't, he's not confused between yes and no, and also the person we saw before, when he said this "tata" and meant yes and no, it seemed like he knew what he meant to say.
Yeah, he also has the impression of very, very good comprehension. And he does, very much like the first patient. Though with the boy kissing girl, girl kissing boy picture task, he also fails, but also shows the same level of confidence that he's gotten it right. Yeah. Yes?
I was just thinking, because when he's thinking about the wife, and then he has hard time to find whether it is a wife or sister, so about grouping, but when he's talking about the emotions, it was fabulous, and there he's much more comfortable because he could say it was amazing, it was super duper, so he seems more comfortable to explain that, yeah, like word, that you could choose any word, yeah, and there he doesn't just, also after he said coffee, he was thinking for a second whether he used the right word, and with fabulous he was just too comfortable.
Yeah, yeah. These are all great observations. You all are going to exceed very, very well as a physiologist, I'm sure. Yes, so what he's doing is he's using, first of all, a lot of emotional laden words, and those do tend to come easier to aphasic patients. Another thing he does that you may notice is when he was talking about, oh, I want to drive there really fast, he doesn't say, I drove there really fast. He says, right? Uses a very different mode, but again, a communicative strategy, right? Good. How different is he from the first patient? It's weird, huh? They both have the same diagnosis, so what's going on? Yes?
He has many more words, but
yes.
Still he's using a lot of automatic speech.
Yes.
Like he has 2 weeks, nevermore, they seem to come out.
Yes. Yeah, absolutely. So those little automatized pieces come out really well. He has more of an ability to produce the things that he's thinking about. Does he come up with the right word every time? No, we saw he doesn't. So he still struggles with that. And we know that he has some difficulty in understanding more complex grammatical constructions. Yeah.
Can I ask a question?
Yeah.
I think that if we would run the aphasia test better, the first patient would come out as a global aphasic rather than as a broken.
Well, I'm going to show you some test scores. So, but that's a great question. So why does he not, the first one not classify as global, and this one, but Broca's, and that they're both Broca's aphasics, okay? So that's a really important question. And in some aphasia classifications, that might indeed be the case, if the classification is dependent only on output. And as we'll see in a moment, the comprehension abilities for these two patients is exactly the same. They both have exactly the same deficits, yes? His counting? Very well, again, up to 10, 11, 12, and then not so good anymore. Yeah, yes?
So also like making up words? Like mixing like phonics?
No, he doesn't do that. So in the first case, his recurring utterance, we call those recurring utterances, the things that come out over and over again, happens to be jargon. It has no meaning. In this gentleman, he's not reduced to that. He can produce some things. So if he's going to produce something, he'll just struggle to find something that's at least a little bit close. Yeah, and you had a question.
Yeah, do those patients also have a problem with memory? So like if they don't find the word, it could also be related to memory. Do they, for example, remember their neighbors' names or their own birthday or something like that?
Yeah, that's another great question. And it kind of speaks to the way language and memory kind of overlap. So we'll have patient spouses say, well, he just doesn't remember things. Well, we have to probe that. What does that mean? Does he not remember that he ate breakfast that morning? Or does he not remember the word breakfast? Very different anatomy too. So we have to probe that. There's certainly a storage of those lexical items somewhere, and those have to be indexed in some fashion. So does he know when it's his birthday? Yeah, he knows when it's his birthday. Would he track it and remember, oh, today is such and such a date and I need to remember that it's my wife's birthday? Well, he better well remember that, but whether he does or not, yeah, unclear. All right, we came back to the issue of reading and writing. This is his description of this picture from the Western Aphasia Battery. It's a picture that's used very commonly in a language assessment for aphasic patients. And you can see he's written kite, which is correct. Fish, he's probably trying to say that somebody's fishing. Here, probably trying to write boy, cup, radio, dog. I just went dead. The mic went out. In the back? Okay. All right, so you could see that he's getting some of the words that he wants to describe. Others, maybe he's doing tree here. We don't know. There's not enough information there. Okay? So here we see that his writing is also impaired, and hence also confirms that he's got a core language deficit. So let's take a quick look here at many of the symptoms that are involved in Broca's aphasia. Right? So we're talking about that sort of halting, what we call telegraphic speech, that features mostly content words with few grammatical markers. Some people argue, well, they do that because it's so hard for them that, of course, they want to convey as much information as they can. Others say they don't use grammatical markers because they don't have them anymore. They don't have access to syntactic processing. So actually, still something of a debate in the literature. Word finding difficulty, every aphasic patient has word finding difficulties. Okay? There are some patients who only have word finding difficulties. We call them anomic aphasics. Okay? So anomia crosses all the aphasias. You will always see word finding problems in aphasia. Usually in Broca's aphasia, there's an accompanying motor speech disorder, a dysarthria or an apraxia of speech, which we'll talk a little bit about later. Comprehension impairment for grammatically complex sentences. We talked about their repetition and also their reading and writing. All right? Now again, what's different between this second case and the first case is the fact that in very severe cases you get these recurring utterances. All right? There's such a blockage of output that nothing can be produced. And yet, let's look here. This is a reflection of their fluency. On a scale of 1 to 10, the first patient gets a 1, which means he's producing something even though it doesn't carry a lot of meaning. But this patient gets a 4. Repetition, this patient can hardly repeat anything. This patient does okay, but fails on sentences. Naming, again, out of 10, only can name 4. The first patient can't say anything because he says tono, tono instead. But look at their auditory comprehension. If they listen to a sentence and they just have to point to the object or sentence or picture that you're talking about, they both do the same. They get approximately the same score. It's not a perfect score. Okay? They start to fail when prepositional sentences become involved, things like that, prepositional phrases. Yeah, Simon?
How do we judge these scores in relation to population norms?
Hopefully you and I would get 10s on everything. Yeah. It's really, it's not a very sensitive test for people who have word finding problems. So an anomic aphasic can also get pretty much 10s or might just only have an 8 or a 9 on the naming subtest. So it's not a difficult test, really, overall. All right, how are we feeling about a coffee break? Okay, let's do that. Let's take a break, and then we're going to talk about localization of Broca's aphasia, and then we'll go to Wernicke's and localization and some of the other methods that we use that are really exciting and fun to explore.